So I'll move on now to introduce our first plenary speaker, Professor Patrick McGorry. Many of you probably don't need an introduction to him. He is kind of the guru of early intervention services. Professor McGorry has been a good friend for many, many years. I have learned a lot from him. And from the way he has gone beyond psychosis into the entire field of youth mental health. And the same, I will say later on when Professor Max Birchwood will speak, because that's the same kind of thing that they have done in England. I'm not going to give you a long resume on Pat's achievements, but suffice it to say that Australia recognized his contribution, and he might be the only psychiatrist anywhere who got the award of, he has been awarded the Australian of the Year in 2010. The other thing I have never really learned from Pat is how he persuades governments to give millions and billions of dollars. Maybe someday that will trickle down as well. So without further ado, please welcome Pat McGorry to give us the first plenary. Thank you.
This one? Yeah, it's a big slide.
Thanks, Ray. Yeah. Well, thank you very much, Ashok, and good morning, everyone. And the first thing I'd like to say is thank you so much for the privilege of being invited back here. I came here, I think, around the time soon after PEP was started here, so it's a real privilege to be back here with Ashok and Max and Ross and everybody else celebrating this great 10 years of achievement. Now, Ashok, even though he said enough of that, I do have to say a few things about him before I start. Of course, many people in the audience know that Ashok had already made a huge contribution along with Ross and Raul Manchanda and others and down in London, Ontario. But he was able to replicate this and probably go to another level here in Montreal, which is very, very impressive to see. And because of the things that Mimi was saying about him, I think he is a great chef. And the thing that he did, I think, in the field, which is different and very special contribution, is that he emphasized the importance of the quality of the service for the young people with emerging psychosis. A lot of people, were very taken with the idea of early detection, and all you had to do was just find the patients and everything would be fine. But we know that the quality of mental health care in public psychiatry, even in rich countries, leaves a lot to be desired. So just getting them into a service which isn't necessarily geared to their needs and they can engage in was a key contribution to emphasize that in debates within the early intervention field. And Max also made the same point too. So I think that's a very important thing to emphasize. But he's been a great friend and tremendous. This has been an international network, which I'll talk about, and we've all supported each other in a way you don't often see in psychiatry. So it's a real privilege to be here. Okay, so I'm just going to try and talk, I don't know how far we're going to get with this, but I will try to do this. Talk about early intervention as an idea. I'm going to talk a fair bit about the psychosis risk idea because that's something that was very controversial in relation to DSM, and it's important that we get the facts clear about this. A little bit about staging, and then if there's time to talk about what I think the Beck Foundation here in Montreal is catalysing in a brilliant way this move towards youth mental health, which Max and I have both been involved in, and I think it is the next frontier, and it might actually solve a lot of the issues that we, still need to solve if we can make this paradigm shift. I think also Andre was talking about that too in a good way. So basically, this is not rocket science, any of this. So, it's a simple proposition. And this was a quote from the founder of the Royal Flying Doctor Service in Australia in the 1919, John Flynn, who said, if you start an idea, nothing can stop it. Well, that's not strictly true. There are lots of really great ideas that didn't get implemented. So what we have to do is stage manage and sort of put the idea on the ground in real life. And That's what we are, PEP has been doing, and many other people. When I started training in psychiatry, this was the idea that was put in our heads about schizophrenia and psychosis, that this is a 19th century sort of image, but that was the idea, dementia precox. People were told, believe it or not, when they came in with their first psychotic episode, you have schizophrenia, you will not get better. You will just plan to adjust your life, so you probably won't work, you probably never get married, get used to it. That's what psychiatrists would say. And if you try to put forward a more optimistic scenario, people were referred to as promoting rescue fantasies. Can you believe that? That's the way psychiatry thought. And I think Max gave a quote once that the management of schizophrenia was like the management of the British Empire, the orderly management of decline. And I love saying that as an Irishman. So this is a Norwegian slide from one of our friends in Norway, Jan Olav Johannessen. And this is what traditional services, it's not their fault, but they were just so underfunded and poor morale and so on. And they were only able to look after people late in the piece, when people had already experienced a lot of damage. I think Andre made this point as well, that early intervention was not really on the horizon. And yet, if we actually pick people up early and we look after them properly for as long as they need to be, and this is an issue that Ashok's research here is trying to tackle, how long do we need to provide this more specialised culture of care for, we probably can modify the course of these diseases. All the evidence that we have so far points in that direction, even though it's critiqued by skeptics and genuine skeptics, and also people who are trying to oppose the reforms. But the evidence is almost universally indicative that you can change the course, and we need to change it more powerfully, but the indications are pretty positive. And even if we didn't change the ultimate outcome, the fact that we relieved a tremendous amount of distress and reduced disability while we're working with the patient, that's of value in itself. You think about the treatment of rheumatoid arthritis, even if you end up with a fair bit of disability, if you can give the person many more years of functional life in the meantime, that's of value, and you reduce pain and suffering. But it's funny, in psychiatry, the standard of proof that we are held to in early intervention by some of our colleagues is if you don't cure schizophrenia, if you don't actually permanently alter the course, then it's a waste of time. You might as well let them deteriorate and to whatever level they're going to deteriorate, and then look after them in a kind of palliative care way. That's the actual argument that's being put by some of our critics in this area, believe it or not. Okay, so some of the history from our Australian perspective. I mean, we started off working with first episode patients in the mid-80s. We were lucky because we started to focus on these patients, and immediately you could see that the clinical needs were quite different from patients with later stage illness. We set up EPIC in 1992, and I was fortunate enough to meet Max Birchwood around that time. He came and spent a sabbatical with us in 1993, and we worked together. He was very successful in the UK in rolling out, getting the government to roll out early intervention services there. In Canada has made a very big contribution compared to other countries in developing early psychosis programs. Most parts of Canada have made a good effort at that. I wouldn't say it's universal across the whole system in Canada, but there have been leaders in Canada who have been very collaborative, and actually, Canada's made a big contribution to this issue, and especially through the work of Ashok. And also I'd mentioned Jean Addington in that connection as well. So we basically formed a club, which was, the International Early Psychosis Association, and it's had its first meeting, or the first international conference, was in Melbourne in '96. But there have now been there's been a lot of growth in this organisation over the years. 60 different countries have members. There's 4,000 members internationally, which is a big number for an international organisation in psychiatry. This was the 8th meeting in San Francisco last year. The next one is in Tokyo. So Asian centres are coming on board in a major way, and that's a very important development. So it is a paradigm that's taken off, in many places. And there's quite a good evidence base now. This is a study we did a couple of years ago for our federal government, capturing all the international evidence and showing what elements are necessary in terms of a system of care. And there are 16 elements, believe it or not, necessary for an early psychosis program. And they include things like home-based treatment, 24-hour home-based treatment, so inpatient care is not needed except for a small percentage of patients. Assertive community treatment, specialised interventions of various kinds, inpatient, outpatient care. It's a comprehensive system that's required, and that this captured this, and this was the blueprint for our federal government's recent scaling up of early psychosis. I think I said that already. I just make this point that we're still not quite sure how long we need to intervene for to achieve this more sustained improvement in terms of disease modification, and that's Ashok's study here comparing 2-year versus 5-year intervention is going to be an important contribution to that, and also in Denmark that work is being done, because we know that you get better outcomes at 2 years with these more specialised programs, but some of those gains are lost at 5 years if you discharge the patients back to standard psychiatric adult care. And that's not a surprise, is it? Because the patients don't engage, they're seen much less frequently, and it's not surprising that the outcomes start to get eroded. It's not a criticism of the services, it's actually just the approach and the level of input. So Ross and his colleagues working with Ashok, I think, showed that even if you retained the patients, if I got this right, within the specialised early psychosis program at lower intensity for another 3 years, you didn't necessarily have to provide the full level of care. That was still better. The outcomes were maintained by 5 years. So that put the critics who were saying that it was a waste of time to actually have got better outcomes at 2 years if there was some erosion of the outcomes by 5. Some people actually argued that we should stop doing early intervention because the outcomes were not sustained at 5 years. Actually, this shows what should happen, that you build on those gains and you try to maintain them as best you can, and or maybe even go further. Because many patients take longer to get better, but they get really well. There's a medical student in our program. There was actually a patient in our program who became, 10 years later, a doctor. He actually had 5 years of very severe illness. He began to improve, and he went back to university and became qualified in medicine, and he's now about to enter psychiatric training. This is after several years of psychotic episodes. Universities would have kicked him out 20 years ago. Now he's actually on the verge of becoming probably a very brilliant psychiatrist. So this is the sort of thing, sometimes it takes longer. Is it cost effective? Well, again, I think there are probably about half a dozen studies now around the world which all point in the direction of cost effectiveness, especially the UK work is very, very robust, done by the best people in the world in health economics, in mental health. But we've still got critics, people will pick holes in these studies and try to argue the reverse. But the general, if you're unbiased and you step back and you look at the general thrust of it, it's very encouraging in terms of the value for money proposition, even with what we've done so far. And there's more evidence of that. This is the UK work. In terms of the value of early detection, this is the TIP study from Norway, which all it did was really focus on reducing DUP, the duration of untreated psychosis. So it did that by massive community education programs and mobile detection teams that would actually find the patients and bring them into care. And Norwegian mental health care is quite good compared to most parts of the world. Even the standard adult care is not bad, but it's still not of the quality of what you would have in PEP. It's not as phase specific or and so on. So, but anyway, they found that there was an improvement in outcome, even at 10 years, in terms of functional outcome for these patients. It wasn't dramatic, but it was twice as good as the patients that had just the normal detection as usual with, just longer delays in treatment. So shortening the delay for first treatment had long-term effects. So, and that's another issue for the critics to deal with, because that actually is some evidence of modest disease modification over a long period of time, if you accept the results of this study. So, again, you can always question research, but the general direction of all of this evidence is pointing in a very favourable way. And to the extent that it's not more dramatic, it's really the failures to deliver high-quality care consistently across the whole course of illness that's actually undermining the much better outcomes, I think, for patients. Okay. Now, just a little burst here on the current state of play with therapeutics. The problems that we have still are low expectations for patients. It's what was, I think, an American speechwriter for George Bush described as the soft bigotry of low expectations. In other words, near enough is good enough. If the patient's reasonably settled and not too disturbed, well, we'll take that, rather than aiming for full recovery wherever possible. And that is a kind of stigma. It's a type of bigotry. We don't say that to patients with physical illnesses, with cancer. We're absolutely, desperately striving for the best possible outcome for these patients. Whereas in relation to schizophrenia in particular, we're happy if the patient's not in and out of hospital, even if they're sort of sitting in their bedroom playing computer games all day. That's okay. They're not causing any trouble. That's the bigotry of low expectations. And we have got very weak delivery. Very weak, especially as Ashok alluded to, community-based delivery of care. I won't go through that, but we've got an editorial in Press commenting on this study that I'm just going to tell you about in a second. We did some work, Mario Alvarez, one of our psychologists, and a whole group of people looking at long-term outcome data in our first episode cohort of about 700 patients that we followed up over about 7 or 8 years. And the biggest predictor of functional recovery at longer-term follow-up was whether the patients made an early functional recovery. In other words, if you could get them back to school or work, even if they weren't totally well, that was a great predictor of how they were going to do in 7 or 8 years' time. Symptomatic remission on its own was not a greater predictor. So the thing that we try to do, we try to obliterate the illness with medication and get rid of all the symptoms. Obviously, it's a good thing to try to do to get symptom resolution, but you've got to do a lot of other things as well. That's not enough in itself. And that's what they showed. In fact, that they showed that 31% who achieved full functional recovery at both 14 months and 7.5 years had failed to meet remission criteria at 14 months. In other words, these are patients that made a good functional recovery but hadn't been that well, in symptom terms at 14 months. Only 14% of those who attained symptomatic remission at 8 months and failed to achieve full functional recovery at 14 months went on to fully recover at 7.5 years. And interestingly, of those who did achieve full functional recovery at 7.5 years, and it was quite a big percentage, I think it was at least 50%, 61% of these had not been taking antipsychotic meds during the last 2 years. So there is a need for medication early on. It's probably a very minimal need, actually. I'll come to that in a minute. Low doses for most patients. And many patients are able to actually move past the need for medication in the longer term, according to the results of this study, and still have a good functional recovery, which is a very positive thing, if that's true. Okay, so this is why this holistic recovery approach is really important. The young people are developing an illness at a critical developmental period. They're at risk of losing their protective factors like work and social support. Everyone knows this that works in the field. They see this before their eyes. And if they end up on disability payments, that's a really great predictor of being chronically mentally ill. So trying to avoid that pathway is really important. So what we need to do is try to maximize engagement in work and personal relationships and education, creating positive emotions. The whole positive psychology ethos is something we really need to look at in relation to how to work with patients, and creating a purpose in life or helping them find a purpose in life at this developmental stage is very important. And then you get into a positive cycle instead of the sort of negative spirals that we often see with young people. Now, this is not easy to do. You need, great people working with the patients. You need, perseverance, and you need to kind of work with them over a period. Vocational interventions are proving to be very effective for those that seek them out. So compared with the usual functional recovery of about 50% in the first year or two, if you have this employment or education expert side by side with clinicians in the program, not referring to a job agency down the road, which is virtually useless in Australia, but having the employment person on site working with the team, the recovery rates are 85-90% for these patients that actually are supported in this way. And this has been replicated in California by Keith Nechterlein's group. So this is a very positive development, showing that the old advice, if someone had a breakdown, if they were at university, or take a year off, go back next year, don't stress yourself too much, that's exactly the wrong thing to tell most patients. You try to get them better and get them back into the pathway as soon as possible. And this yields much better results. So this is quite a robust finding now. Now, about medication. This is a very important paper. I'm probably not allowed to say which journal. I should have taken that off the slide because it's not actually published yet. But so I'm going to have to wipe this from your memory banks. But Wondering, Lex Wondering has got this. He presented this study in San Francisco last year. It's a Dutch study, and it randomized 128 first episode patients who'd made a good remission. Now, I've got to stress that's only about 50% of the patients, so this is not generalizable to all patients. There's another group of sicker patients who don't do as well. But the ones that come good really quickly, if you randomize them to the usual thing of maintenance medication, continuing on continuous medication in the longer term, versus an attempt to get them off medication, which obviously most of these patients want to come off medication if they can. They think they're better and they feel better, and it's a real pain to have to take medication. It reminds you of the fact that you're ill, the lifestyle change, all the usual reasons for non-adherence, especially if there are side effects. So randomization to those two groups. And they reported the 18-month outcome a few years ago, and it didn't look good. The relapse rate was twice as high in the patients where you had tried to take them off the medication, sort of showing that the medication does actually protect to some extent against relapse. But if you follow the patients up at 7 years, it's quite a different story. The relapse rate was roughly equal in the two groups by then, and the level of functional recovery was twice as good in the patients where you had tried to reduce the medication earlier on or stop the medication. Now, most of the patients did not succeed in totally coming off the medication. Some did, but the rest were on very low doses, like, say, 1 milligram of risperidone or equivalents. So the message of this is that we are actually over-treating those patients that respond well. We're giving them too much medication, and that's probably interfering with their ability to actually re-engage with life. And that was the first thing I noticed when I started in psychiatry, how much medication people were getting. It's probably 10 times as much as they really needed in those days, and these days it's probably 3 or 4 times as much as they really need. And I'm not talking about the patients who are more treatment resistant, so we've got to park that one and study that as a separate issue. But for those patients like this who do get good remissions, we've got to be very, very careful about how we treat them. And this is even leaving out psychosocial care. These patients didn't get the PEP-type treatment. If they had had that too, the outcomes might have been even better in terms of functional outcomes. So what I'm trying to say is if we are much more sophisticated and I suppose dedicated about resourcing and looking after these patients properly, I think the outcome is so much more optimistic than you saw in that first slide, that nihilistic sort of picture. We've also got to study the treatment of the more treatment-resistant patients, though, because that's more challenging. There's definitely other types of strategies we need to work on there too. But even the ones that couldn't ordinarily do well, we're not managing them appropriately at this stage. So the key messages of all that are: positive symptom control is a desirable means to an end, but it mustn't be the sole or dominant target of care. If it becomes the sole target, then outcomes can be worse, not better. And sadly, that is the sole target of most mental health systems around the world that I've seen, symptom control and very little else. The other outcomes are crucial, but they must have serious interventions to target them, and unfortunately they're all F words. Functioning, fulfillment, so this is where the positive psychology thinking can come in. Financial, so work and financial planning. Fun, again, positive psychology. There's got to be some reward in life for these kids, Family, peer support, family interventions, physical health. They're at risk for, is that French? Or, so is the physical health is becoming a very big issue, not just because of the medications, not just because of the metabolic syndrome and the risk for the medications, but because of the poverty and the disadvantage and the smoking and all the other things that go with it. Focus on other syndromes, comorbidity, And of course, maximal personal choice. I think I was talking to someone yesterday about how we have to work. Maybe it was a male. I'm just trying to think who told me this, but helping people to learn, how to manage their illness, and you have to make mistakes. They have to be convinced they really need, the sort of things you're trying to offer. We would all be the same. We wouldn't just accept what we're told through psychoeducation. Anyway, so in terms of Australia is a country that has a public holiday every year for a horse race. So horse racing is very important in Australia. So what we're talking about here is the best bets in mental health care. And early intervention is definitely one of the best bets. And in terms of convincing government, Ashok, Max has been able to do this. We've more or less been able to do it in Australia. To convince government that it is a best bet. Convincing some of our colleagues, on the other hand, is quite difficult because... but generally speaking, they're getting there, I'd say. So what level of evidence do we need? This is a mural in Boston. It's about climate change, and it says indication of harm, not proof of harm, is our call to action. So how much evidence do we really need before we should start investing in this? I mean, we've got every evidence you could care to mention in terms of the damage being done by neglecting patients in terms of early detection and giving them poor quality care. So, I mean, I think it's a similar issue, I think we can assume that provided we've got effective treatments, offering them early and in the right way and in an evidence-based way is probably a good thing to do. But, again, it becomes a debate. The Cochrane collaboration is usually used as the gold standard as to terms of evidence-based care, but it was really designed for individual treatments like drugs or individual psychological intervention. It wasn't designed for health system research. So when you try to fit health system research into this prism, it's very hard to get evidence of the kind of stratospheric quality required under Cochrane to actually to prove the case. So critics will always be able to seize on this and say, oh, look, there's not enough evidence, we've got to wait another 20 years. Meanwhile, So I had to write a critique about this because the Cochrane Review of Early Intervention was lukewarm, you've got to say. That the authors wanted to be positive, but the methodology of Cochrane didn't permit them to actually say what they really believed. And so we just made the point, and a lot of people have agreed with this point, that we need other methodologies apart from RCTs of massive health systems, because that is very unfeasible. Very few people are able to do that. Anyway, so we could debate that if you're interested. So to get this reform up, coming back to the political side of things, I mean, the way we do things, I suppose, in medicine and in science is that skepticism is a valued thing, and it's an appropriate thing, because in psychiatry it's full of the history of enthusiasms that were no good or dangerous. So we've got to have the scientific method and skepticism in place to protect us against that and to make sure we learn how to do things properly. But even when that's the case, you've got to understand the sociology of reform. So, there are early adopters, there are innovators, early adopters, and there are late adopters who are just more conservative people that require a bit more convincing, and that's fair enough. It's good to have late adopters, actually, because it kind of keeps things, a little bit more stable. But then you've got the 10 to 15% of, you could call them Luddites, or I call them denialists, that even when the evidence is actually pretty good, they'll still fight against it. And you see that with a number of things. You saw it with the tobacco and smoking and lung cancer link, where science was actually misused to sort of retard the sort of reforms that were needed, with asbestos. And arguably you could see it with climate change, where you also have denialists using science to actually cast doubt on something that's actually, probably quite true. So this great book was written by an American historian describing the tactics and the processes that go on here, called Merchants of Doubt. And it is an issue of introducing doubt into the public mind and then slowing up reform in some cases. Now that's probably not the major issue retarding reform in this area, at least not in Canada, I don't think, but certainly in Australia we've seen some of this sort of behaviour. Now, to speed up a bit, this is a very crucial issue, this issue of the risk syndromes, and it became very controversial in the context of DSM. As you all know, people don't develop psychotic illnesses overnight, and they don't come into the first consultation looking like this. with a big sign saying, "I have psychosis." Psychotic illnesses like schizophrenia develop quite slowly in most patients and in a subtle way, and manifest through, I suppose, things which are quite confusing to the people around them, the parents and the teachers and so on. Social withdrawal, I suppose, is one of the key things. Failing performance at school, let's say, and sort of non-specific type things like that. Anyway, over the last 20 years or so, this process of becoming psychotic has been mapped quite carefully in retrospectively, but also prospectively. Risk criteria have been developed based on the clinical presentations. Warning signs of psychosis have been defined, which actually predict. I'll have to come back to that. So, and what is more noticeable is the level of disability. The functional impairment is really obvious, but you're not quite sure what is going on in terms of diagnosis with this patient, because the actual psychopathological features are sort of subtle in these patients at this stage, and subthreshold psychosis and maybe anxiety, depression is very common. So you know something's wrong. There's a need for care. The person's functional level is in the 50s on the GAF score, but you can't quite squeeze them into the DSM, that neatly. It's a very attractive idea to intervene there, because you might be able to prevent some of that disability getting entrenched at that developmental stage. But if you wait till the treatment of the first psychotic episode, and maybe some time after that, then you certainly can treat the positive symptoms, but the disability is much harder to shift. Now, the arguments against this are that many of the patients that look as though they're going to become psychotic don't actually progress to psychosis, and so there are false positives, and there's a risk of over-treatment, especially if you're thinking of treating with medication. So this is a very important thing to get right, just like we do with other forms of early diagnosis, not over-treating, but not under-treating either. This is a painting by someone in this stage of illness. You can see it's not a pleasant sort of subjective experience. And there are brain changes during this stage too. We're not quite sure what they mean, but it looks like it's an exaggeration of the normal pattern of grey matter loss during this period of life, and I'm sure Stefan and others are going to talk about this. So there's been an explosion of research in this area over the last 15, 20 years. So this is the rise of papers. There were virtually no papers on this issue back in the early 90s, and now there are a significant number of papers every year around this issue. So whether or not it's in the DSM, it's certainly in the conferences and the research grants and as a key area. And Jim Van Os is someone that's contributed a lot to this area, because he's shown that these warning signs of psychosis, these sort of suspiciousness or perceptual disturbances are actually not uncommon in the general population, and they don't always mean, they're not always warning signs of psychosis. It's really the company they keep. If you see these symptoms in the context of depression, anxiety, and failing functional performance, that's when they are important. And they're not just important for transition to psychosis. There are other poor outcomes associated with them too. So, in terms of prediction, are we justified in using these terms? And this is one of the debates that we're having. It's not the situation that everyone that has this clinical phenotype will go on to develop a psychosis. So it's not like this little elephant. He's going to grow up into an elephant. He's not going to grow up into a tiger or a lion. So, there are more than one outcome for this picture. So is it just a guessing game? I mean, like catching a plane in America. It's not exactly like that either. In fact, we can predict with these operational criteria that the transition rate at 1 year is about 30 to 36%. About 3 years it's about 36%. So that's, a third of the patients are becoming psychotic over a 3-year period, which if it was a blood test, it would be, actually used everywhere, this sort of, this concept. Because that positive predictive value is very high. There's an issue about it, the predictive power falling a bit the more we do this work, which maybe there's a dilution of risk in the populations we're looking after. Maybe our treatments are getting more effective for them. So that's an area of further study. But I just contrast it with diabetes, where the pre-diabetic state, even just a biochemical state, not a clinical need for care, is taken very seriously. And people are offered lifestyle change to get rid of that biochemical vulnerability. And if that doesn't work, they're offered potentially medications to actually treat that risk state. And that's much less controversial than what we have seen in the case of this subthreshold psychosis, probably because it is a blood test, and there's a different sort of value placed on that. So there's a lot of ideology rather than logic in what we do in psychiatry. So I think, we could say we're not just guessing. We've done enough research to say that we have defined a clinical picture that is associated with risk. And we can enhance that even further with adding extra clinical variables in so that the PPV is up to 80% as well. And that was also shown in the Naples study. Yeah, okay, I'll skip that. So about 10 intervention studies have been done to try to reduce that risk over the last 10 years or so. And Mark van der Kaag from the Netherlands has done a meta-analysis which has just been, I'm not sure if it's accepted, but it's in the final stages of review in one of the schizophrenia journals. And basically all these studies taken together are positive. And basically he says everything works, and the number needed to treat, which is the index of the power of the intervention, is low, which is good. It's 8, means that you treat 8 patients to prevent 1 psychosis. And just to give an example, the number needed to treat with hypertension to prevent stroke is 113. So 113 people have to take medication for hypertension for a year to prevent 1 stroke, and people do that. Here you have to offer treatment to 8 people to prevent 1 psychotic episode. So it's an efficient sort of thing. CBT is the best candidate because it's the safest and it seems to be effective, even though it's a bit more expensive. More acceptable probably to most patients. But other things like antidepressant medication might work. Omega-3 fatty acids, there's one trial of that. And maybe even just simple psychosocial intervention more generally might work too. Antipsychotics probably work too, but because of the increased side effects and risks, they're certainly not advocated for first-line treatment in this group. Okay, so how do we move this field forward? One way would be to increase the efficiency of these criteria by making them more predictive, by trying to add biomarkers in and try to enrich the prediction. And that's probably what will happen in the schizophrenia silo of research. But I think there's another way to go, which is to try to recognise that these patients also have risk for other syndromes as well. So why not turn that to advantage and try to predict risk of depression, bipolar, and other major outcomes as well. So I'm going to go through this pretty quickly because I want to get to the last bit about the youth mental health. So increasing the efficiency, it's really a question of sequential screening. And, we're sort of, if we just go in one hit to the general population, we're really looking for needles in a haystack, which is a very difficult thing to do. What we ought to do is just look for, all the sharp objects, basically, which is all the distressed young people. And within that group, then look for these ultra-high-risk patients because the mathematics of it means that you're probably going to be able to find them, with a 2-stage approach. And to do that, we actually have to find ways of drawing young people into care. So if we're going to find the sharp objects, it has to be a bit more magnetic than currently our services are because they're not very attracted to them at the moment. And I'll come back to that at the end. Again, the Dutch have done really good research here. They've actually shown the 2-stage approach with using the prodromal questionnaire in a triage system. It gives a much better yield of finding these patients. And also the transition rate to psychosis amongst the ones they do find is higher. So this strategy probably is going to work. This sort of sequential enriching is if you're looking for psychosis. The other way to go is to try to use this staging idea borrowed from cancer in a broader way, so as a heuristic idea. And this is the outcome data from 400 patients with this prodromal or ultra-high-risk state that we have treated in our PACE clinic over the last 15 years. And what we see is that while 30%, 40% of them become psychotic over that period, the rest, maybe about 10, 20% get completely better and they're fine, but the rest actually have more persistent mood and substance use disorders, mood anxiety and substance use disorders. So they are a morbid group. They're a group who have got a need for longer-term care more generally, even beyond psychosis. So that means that even when we're trying to predict psychosis, we're capturing a group at risk for other things too. So rather than do this and just focus on psychosis risk, I think we need to go more broadly across the spectrum of diagnoses in this or syndromes in this age group and try to look at other destinations. And This is sort of what DSM would have tried to do. It would have tried to define specific risk syndromes for the traditional disorders. But it's very unlikely that you can actually separate these syndromes at this early stage. They overlap too much, just like you saw from the previous data. So it might be better to do something like this, to recognise that patients in the real world, and these are the patients that we see in our primary care youth clinics, they haven't read the textbooks, they haven't read the DSM properly. So they come in with groups of symptoms that are fragments of the traditional syndrome. So they have a bit of anxiety, they have some panic attacks, they have some depression, and they might have some intermittent perceptual disturbances which might make you think they're at risk of psychosis. But they haven't got a full syndrome of any of these things. But the symptoms they do have are associated with quite a bit of functional impairment and distress and relationship problems, and that's generally why they come in, because they're distressed and they're struggling with life in one way or another. And when we assess them from a psychiatric point of view, they've got these sort of sub-threshold pictures. Now, most people would turn them away. Sorry, you're not severe enough. Come back when you're really psychotic, or when you're suicidal, or when you really need help. That's the sort of message they get from traditional systems. So, but we're saying that's a stage 1 type problem, and the actual subtype of disorder is not important at that point. They have a need for care, and most of our treatments in psychiatry are quite non-specific. CBT is a cross-diagnostic intervention. Supportive case management is cross-diagnostic. Educational interventions are cross-diagnostic. Even most of the medications are cross-diagnostic. There's no magic bullet for each different disorder, except with the possible exception of lithium for bipolar. So we've got too many categories. We've got too many subdivisions in psychiatry. If we want to simplify it, we simplify it by broad syndrome and also by stage of illness. And the key thing about staging is the stage of illness influences the treatment selected just as much as the actual problem. So with breast cancer, for example, the treatment of stage 1 breast cancer is completely different from the treatment of stage 3 or 4. You have to know what stage the illness is at when you're selecting treatment. And that might also be the way we need to think about these psychiatric diagnoses too, that, for example, the treatment of subthreshold psychosis is quite different from the treatment of someone with 10 or 15 years of schizophrenia who needs clozapine and a whole range of other sort of types of psychosocial interventions. So stage of illness might be very important. Now, we can't implement this yet because it's really a framework for studying the next, the future, the next period, to see if this is actually helpful or not. So there's a lot of things written about this, starting to influence research strategy. I think I've said all this. You can define stages in this way operationally, and the treatments are obviously much simpler and safer in the early stages, which is a key point. And some people have tried to say, well, this is promoting early use of medication. It's the exact opposite. It's actually saying, it's trying to research when medication is necessary and for which patients. And so the last thing you'd want to do is get into these early stages of subthreshold disorder and be prescribing, because most of them need much more simple psychosocial types of interventions, even things like exercise and education. Biomarkers haven't been studied at this stage properly. It is influencing some of the thinking. This is Thomas Insel's paper in Nature, I think it was, where he used this staging framework to apply to schizophrenia. It's been depression, bipolar, borderline personality disorder, another critical understudied area, eating disorders as well. Okay, so just in the last little while, I'm sorry if I rushed that, but I'm really happy to explain it a bit better if people have got questions. But it's really just trying to show you that you have to think very carefully about how to do these things, and we've got to put the diagnostic silos on one side, because we can't assume that these terms, schizophrenia, bipolar, and so on, have got as much validity as we've always given them. They're descriptive things, and we've got to look at people in a much broader way and work out when diagnosis is useful. The only point of diagnosis is to help you with treatment selection. So this is why a staging dimension might help you with treatment selection as much as recognising what syndrome it is. So, bearing that in mind, how do we actually start to do this in the real world? How do we actually learn more about these things, and how do we start implementing the knowledge we already have, which isn't getting to so many young people? So this is about reform, and it's about creating cultures of care for creating new knowledge and novel therapies and better outcomes. So why young people? I think Andre's already said some of this, but basically, this is a paper from Nature a couple of years ago, which is about the mental wealth of nations, and it's making the point that, it's not just a question of needing a village to raise a child. A whole society invests in its children and gets them to the point of productive life. It gets them to 18, 22, and nurtures them, educates them, gets them so they're ready to go. They're ready to be productive. They're ready to contribute to society, to develop their careers, to pay taxes, to have children, and to bring the world forward in that way. If they become disabled at that point, and the biggest cause of disability and premature death in this age group is mental illness, if that happens to them, then it's a disaster, not just for them and their families in terms of distress and suffering and loss, but also to the whole society. So much so that the British adolescent forensic psychiatrist, John Gunn, described the neglect of adolescent mental health as a major form of self-harm by the society. And it is, just even in economic terms, and that this paper really makes that point very clearly. Even the World Economic Forum is recognising this now, because it's pointed out that the biggest equal cause of threat to GDP in the world, alongside cardiovascular disease, is mental illness over the next 20 years. And that's because it strikes in this major period of productivity. So if you become disabled or if you underachieve, the effects occur over decades. It's in young people, and the effects are exerted over the lifetime. If someone has a heart attack at 65, well, it's not good, but they've been able to have a productive life and contributed up to that point. So the economic impact is not as big. So this is why we've come up the league table in terms of public health importance. Unfortunately, no one's told the politicians that yet. So economic reports and cost-effectiveness data is really important. This is just underlying visually what's already been said, that in terms of physical illness, the burden of disease is mainly in the over 50s and in younger children. So we have paediatric hospitals for physical health, and we have the whole health system operating on the over 50s. In the middle, especially teenagers and young adults, we're very physically healthy these days. There's not much need for medical care in teenagers and young adults. And that's why the system has not been designed for them. And that's why there's a huge hole in the system for the adolescents and the young adults. And yet, you can see that their major health problem is mental health. It takes off around puberty, surges, peaks in the early 20s, and then starts to drop off in terms of new cases. But we have not designed our health system. When we mainstreamed our mental health system out of these old institutions into general hospitals, we forgot to actually look at this and say, well, we need a really strong, youth mental health component there, which actually is going to address this. And we shouldn't actually have a paediatric adult model with a dividing line at 18, because it doesn't fit the pattern of disease that we see in physical health. And even our colleagues in paediatrics complain about the small number of patients who do have adolescent medical diseases and try to make this transition. They'd support what we're saying too, I would think. But it's especially important for mental health. And so the system is weakest where it needs to be strongest in terms of our mental health system. And there's just more data about that. And if we follow young people from the beginning of high school through to age 30, we find that 50% of them will be diagnosable with mental ill health during this period. And I can hear some of you saying, oh, well, that's just teenagers. That's just the teenage angst. It's just the worried they'll grow out of it. But actually, these people showed that there was a direct dose-response relationship between the amount of mental ill health they had during this transition, and of those 50% that had a diagnosable disorder, 50% of them had recurrent disorder. So there's a direct relationship between that and how much money they were earning at age 30, how well they'd achieved in terms of their vocational goals, and how many, even their social relationships, how many friends and so on they had. So it's not a theoretical issue. It's not some kind of philosophical, ideological decision, about it. They just need some kind of practical help. Doesn't mean they all need to be put on antidepressants, but they need some type of help to help them make that transition. And that's what we've got to work out, how to deliver that. In the US, it's even worse. 40% in 1 year, according to this National Comorbidity Study, adolescent supplement, were diagnosable in a given year. So what are we doing? Well, this is probably our response so far. There's a lot of rhetoric about early intervention, but, what's on the ground? And in fact, only 13% of young people in Australia, of young men in Australia in 2008, with a diagnosable mental health problem in any given year, were getting access to care, and 31% of young women. So if that was happening in diabetes or asthma or cancer, there would be a national outcry about this, that they weren't getting any help. And, this is a debate we've been having in the last few days, but just try to, renovate the system a bit and patch it up, or have a transitional program between CAMS and adult, that's not going to cut it. That is just a very limited response to this problem. Because apart from anything else, most of the new incidence is in the 18 to 24 age group, and transition from CAMS to adult is not going to do anything for those kids. They're just going to go into, if they can get into a traditional adult system. So there has to be some. We don't need a renovated building. We need a new building, actually, or a fourth stream of care within the three streams we already have. The three streams work okay for general health care, but they don't work for psychiatry. So this is the bit that's missing. This is Sydney Harbour Bridge in 1927, and luckily they did finish it. And they must have worried if the two things were going to meet in the middle, but that's our challenge now, to build something in between, which actually bridges this transitional period of life and captures the main risk of onset of the major adult mental disorders. Now, obviously, there are some disorders that do appear before puberty, like ADHD and conduct disorder and so on, and they put the kids at risk for getting these other ones later on, of course. But, the majority of these onsets, I think, actually are after puberty, and certainly that's my clinical experience working in headspaces. I would say about a third of the kids coming into our headspace centres would have had some childhood mental health problems, which would have needed help before puberty. But 2/3 of them have been pretty much okay until they hit high school, and then they started to really develop the adult type problems. So we do need a new system. We also need to understand the transition, apart from the public health perspective and the whole clinical perspective I've been putting, we've got to understand the way young people are in the early 21st century. And most of us haven't been properly trained in this developmental approach, even child psychiatrists. They're trained in old-fashioned thinking about adolescence. It's a new world. This is a book from an American author, Jeffrey Arnett, who did massive qualitative research looking at what the experience of growing up in the early 21st century is like for young people. He listened to them, and he defined the developmental challenges and tasks for these young people in the present day. And it's with the global world, it's very similar in most developed countries, and something we've got to get our heads around a lot better and actually create the cultures. Points out that the whole process of becoming an adult has been stretched, so it starts earlier and finishes later. So in some ways they're more mature earlier, but they don't finish the task of actually becoming an independent adult until later on than they did 20, 30 years ago. So it's something we have to understand as clinicians, and we need young people to help us with that, which is all about youth engagement, youth participation in services. So our government has supported this direction. Just skip that. And they've developed a program called Headspace, which is an enhanced primary care model. And it's not a new silo of care. It's actually bringing the existing silos together in a one-stop shop. But it is a physical presence. So it has the appearance of a youth drop-in centre. So it's got a youth culture to it. But it does have, various professional expertises present on site to work with the young people and be a portal for, provision of holistic mental health care and actually physical health care too. That's what they look like. I'll just see if I can show you a quick, short 1 or 2 minute video of this, if it's working.
Western Melbourne Headspace is different to other health services in that we're providing a very holistic look at health. So if young people are engaged with our service, then we're able to provide support around both physical, mental, emotional health and wellbeing, all in the one service.
It's very focused on young people, which is 12 to 25 years. It's quite accessible. You don't have to deal with a very kind of formal clinical feel that some like medical centres and that kind of have. It's very open, very engaging.
There's a shopping centre nearby, so you've always got somewhere to go afterwards. Another thing, the building itself, it's pretty funky, and it's not just what's in it, but there's a lot of space. You don't feel like you're going into a hospital or something, or a clinic. It's pretty comfortable and relaxing.
The Access team is quite often the first point of contact for people accessing Headspace, Western Melbourne. And we have a team of a senior clinician and then 3 part-time Access team clinicians. And so what we're doing is we're an initial point of contact where we might do an assessment or some history gathering, or someone might drop in, and we can meet with people immediately.
Usually the way it's working is that most of the people are coming for their mental health problems, and as part of that process I would do a general checkup, talk to them about any preventative health aspects, issues to do with lifestyle, diet, exercise, substance use, sexual health, and usually during that process then there are other things that they may have concerns about that they will bring up as well.
You have a lot of professionals right here in the centre, like you've got your GPs and your Access team, your psychiatrists, all that kind of stuff. You don't have to go out and come back in and travel all around and whatever else. There's all here under the one roof.
Seeing a GP here is all bulk billed, so it's all paid for by Medicare.
I think the main benefit would be that this service is actually solely dedicated to just helping young people. So when you walk in, you're not going to be surrounded or waiting amongst other adults who may require different needs, or who just may make you feel uncomfortable about even coming here in the first place. That young person has a close friend they could probably find comfort in. They could tell them the problem that they're experiencing, and maybe that close friend could then come with them to the service.
Anyone between the age of 12 and 25 living in the Western region can access Headspace Western Melbourne. Once
you get in, it becomes a weight lifted off your shoulders. It's very fulfilling in a way that you know that things are getting better and you can get and do different things. Just to be able to talk and get it out there is quite good too.
This is our Prime Minister after the 2011 budget, when they expanded the Headspaces quite significantly, and also decided finally to fund PEP-type programs, EPIC programs across part of the country as well. She came and made that announcement at that site, and there's all the young people from the local area with her. She's not going to be around for much longer, though. I don't think. There's an election at the end of the year, and she's struggling in the polls, but it's good that there's bipartisan support for this issue. I think both sides of politics are supportive. So by 2015-16, there will be 90 of these sites across Australia. In our case in Melbourne, where we work, our Origin Youth Mental Health Services, a specialist program, works to back up that system, but that's not the case yet in other parts of Australia. And we actually manage, as a research centre, we will be managing 4 of these centres. We currently manage 2, but we'll have 4 of them, and they will be like our portals and our platforms for I suppose, mild to moderate care. And we will co-locate our more specialised case managers with these sites over time too. So we will have we're building a kind of a more comprehensive stream of care for this 12 to 25 age group, and bridging, the children's hospital services and then the rest of the adult system. So we're trying to gradually build this gap. So this is the sort of money that's been allocated over the last, in 2011 there was the best part of $500 million devoted over 4 years to build this system. And it's still not that much, but you can't build the whole thing in one hit either. You have to build it in stages. And the good thing about this is that when communities see this happening, they feel they're deprived if they don't get these things now. So we've created a dynamic that the brand is seen as positive, the experience is positive. So parents and families and communities want to have these things in their communities, and that was never the case with mental health before. They wanted it in somebody else's community. So this is really a big change. We have to develop the specialisation, and psychosis has been the first thing, but eating disorders is something that's very important as well. Personality disorders, borderline. A lot of these young people have got borderline features, and your standard clinician is terrified by that, and really. We've got to actually improve expertise and confidence and evidence in relation to that sort of treatment. And substance misuse is obviously another big one too. In Ireland, there's the same sort of progress through Headstrong. It's going to be 15 sites. So, and as you all know, Ireland's broke, but it isn't stopping them from doing this. So when your politicians say there's no money in Canada, you don't believe them. It's definitely doable. And this is what it looks like, the Jigsaw, beautiful facility in Galway. And that's the Irish Prime Minister, who's the one that's trying to manage the broke economy, launching the new service last year. We talked about the IPA, and Max and Ashok and everybody have been involved in this international sort of partnership. We've just started a new association called the International Association for Youth Mental Health. There's Canadian, British, Irish, Australian and European involvement in that already, and I think that's what we want to put a lot of energy into over the next little while. We have had one conference in Melbourne in 2010, which was an incredible experience. There were 1,000 people from all sorts of disciplines and involved, including teachers and police and all sorts of people and young people were involved in chairing and convening it as well, and families. So it was very, very inclusive. It also had brain images and researchers and clinicians as well. So that was quite a different atmosphere from the usual sort of conference. The second one is in Brighton in end of September, early October. So if any of you are interested in this youth mental health area, I really would warmly encourage you to come along to that. It's part of the next wave of building reform, I think, which we need all the support we can get for this. And there is an international declaration of youth mental health, which Max's colleague and our friend, our mutual friend, David Shires, had a big hand in. And it's just been published in the journal Early Intervention Psychiatry just very recently. And it basically says what young people should expect from healthcare, from mental health care. And it's got targets in there, reduction of suicide rates, improvement in vocational recovery, those sorts of things that are measurable and should be provided, should be delivered. We've managed to persuade our very conservative College of Psychiatrists to set up a special interest group in youth mental health over the dead bodies of one or two child psychiatrists, but actually, we've got them on board now, and probably half of this group is made up of child and adolescent psychiatrists, the other half by adult psychiatrists that are interested in young people. So there's probably 200 or 300 psychiatrists members of this group now. So this is terrific. We need the young workforce. It's the younger psychiatrists that have gone for it, actually, which is very positive. And so just to finally, this is what we would like to see in the future. Youth mental health as an international field, of endeavour. And also, early intervention, a fundamental feature of mental health care, just like it is in physical health care, and not something like Andre was saying that they all do, but we don't do it. And that's why PEP is such an important thing. Real-world examples of these programs where people can come and visit and be trained in, and that is incredibly precious to actually have that as a resource. And so I think what Ashok and his team have done here and previously in London have been incredibly important. So these are just my people that have different funding sources over the years, and as you can imagine, I had countless colleagues in Australia working on this collaboratively over the years, and international friends and colleagues as well. So thanks for your attention. Thank you.